Professor Dr. T.AJAYAN.MD, HOD, Department of Practice of Medicine, Saratha Krishna Homeopathy Medical College, Kulasekaram, Tamil Nadu, India. Winner of Dr. M.K.Jayaram Award, more than 25 years of experience. The subject is Investigation on Respiratory Tract Diseases with Homeopathic Perspective, Part 1. Yes, it is important to have the homeopathic perspective in all our talks and deeds and even dreams. So on behalf of IFPH, I am Dr. T.AJAYAN. You can have the platform for the next 40 minutes. It's over to you. Please proceed.
Thank you, sir. Is an audible, sir?
Yes.
Okay, and just to share my PowerPoint, just please wait.
Okay.
Is it visible, sir? Hello, sir.
Not
sir, it's visible?
No. This file is not opened. Which one is your file?
Sir, wait.
Yes. No problem. You can take your own time.
Now it's visible?
Started. Wait.
Sir,
Yes.
PowerPoint
Yes,
visible?
okay. Yes, now it is visible. The first slide is visible. Okay.
Okay, sir. Okay.
Yes, good.
Good evening to all. Respected our organizers, especially our Dr. Manoj sir. Then again and again give me an opportunity to present a topic. Today's our topic related to the scope of investigation in clinical practice. In scope of investigation, there's so many topics we are already discussed with you. But today I would like to highlighting the importance of respiratory investigation. Then, like previous classes and all the classes, I will convey with you the importance of investigation. In contemporary science, the investigation is a very, very important one. It will not only help for the diagnosis of the disease, and the same time it will help for the diagnosis of an individual. Then because why I say investigations is play in very important role for everybody know it will help for the diagnosis. Then another very important of the investigation is help for to work out the prognosis of the disease. But sometimes, then especially even the subjective level symptoms are absent, then we are more importance give to the objective level symptoms. Maybe investigations is help for the selection of a homeopathy medicine. That today I would like to highlight it. The investigations are help for the diagnosis of the disease, and as well as it may help for the diagnosis of an individual. That means the selection of a medicine. Then, like previous classes, a doctor has to first aim. Again and again, we are remember the words of H.A. Robert. The first aim is the diagnosis, and second one is the diagnosis of an individual. The lab investigation should be limited to the condition of the patient. If unable to interpret the investigation correctly, unwanted investigation. We are always remember, because in our system is for the very poor people. Therefore, even needed investigation only we are advised to the patient. Otherwise, unwanted investigations is an more difficulty to our patient. The difficulties means then more the bill that just we are highlighting. Then suppose a patient arrive after a allopathy treatment in our place, we are asked to how many rupees you are spent for a treatment. Majority of the patients says then around more than 80% of the cost of the treatment we are used for the investigation. Therefore, my request, unwanted investigations, please avoid it. But needed investigation, definitely you must advise to the patient. it helped to the asthmatic study, and also investigation is a homeopathy part, is a therapeutic study. Then the homeopathy part again, the prognosis the disease, whether it is a cure or recovery. And the system, the broadly that is classified into two categories. One is obstructive lung disease, and second one is restrictive lung disease. It's a broad classification. Therefore, first I would like to highlight what are the obstructive lung disease. There know that nowadays we are after the COVID period, the most of the cases, then after COVID period, it will producing the obstructive and as well as the restrictive lung diseases. Suppose any restriction related to alveoli, that is alveolar membrane, then supposed to be fibrous, is producing a kind of obstruction, a kind of restriction. Suppose then another few diseases, that is the covering the layer, that is the pleura. Sometimes the pleura is fibrous, it will producing fibrosis, it will producing another kind of restriction. Then so many chest deformities also it will producing a kind of restriction. Therefore, obstructive lung disease means normally inside the bronchus, then bronchus and its trees. The bronchus, principal bronchus, primary, secondary, tertiary, then terminal bronchioles, respiratory bronchioles. Inside the bronchus, then supposed to be inflammatory response, followed by the healing by fibrosis. It will producing a type of obstruction. Therefore, all the disease, then our respiratory diseases like emphysema, bronchiectasis, chronic bronchitis, and then other lung diseases. Either we are included, it will a kind of obstructive lung disease or a restrictive lung disease. Therefore, first we are discussing obstructive lung disease. Then obstructive lung disease, one of the major condition is an asthma. Then normally asthma patient is arriving. If then basic pathogenesis is it will producing bronchospasm. Then associated with the shortness of breath is a combination of wheezing, dyspnea, airway hyper responsiveness, then cough, mucus hypersecretion, etc. These are the classical presentation of the bronchial asthma. But in our investigation, then we are directly going to, that is a blood investigation. In blood investigation, first we are work out the presence of atopic. The presence of atopic means we are just to check out then IgE level. Then normally there is bronchial asthma cases in traditional X-rays, it will not producing any sign. But the same time, the bronchial asthma associated with inflammatory response, it will producing certain X-ray evidence, that is the sign of the chronic bronchitis. The bronchovascular markings are prominent. That is followed by, it will producing hyperinflation. Then bronchial asthma, hyperinflation means is producing the complication. It will producing the complication is the bronchiectasis. Therefore, in bronchiectasis, bronchial asthma associated with the bronchiectasis, it will producing the pulmonary hyperinflation. The pulmonary hyperinflation. Then suppose in X-ray, the evidence is there. We are directly going to CT. CT will only help for to work out the hyperinflation. Then second, then X-ray evidence is in bronchial wall thickening. Then third one is the pulmonary edema due to, then asthma usually occurs within acute asthma. Then pulmonary edema, the sign is, everybody know the pulmonary edema means that is fluid collect inside the alveoli. The fluid collect inside the alveoli therefore, each will producing the patchy opacity. The patchy opacity, that is the specialty, is the mist-like patchy opacity. The mist-like patchy opacity is the classical feature of pulmonary edema. Then pulmonary edema, then associated shortness of breath, then etc. Also shows then sign of obstructive lung disease. The obstructive lung disease means then spirometry, the FE1 value is little bit reduced, then FEC value is normal. Okay. Then CT shows decreased lung attenuation around 50%. Then mosaic lung attenuation. That is a CT scan. I already say then asthma associated with the bronchitis. One of the complications of asthma is the bronchitis. Then FEF is a biomarker. Then bronchitis is an already I convey with you is a complication of bronchial asthma. It's a persistent productive cough with the ongoing production of thick tenacious sputum. Then X-ray sign shows the dilated bronchi shows ring shadow or tram track sign. That is then ring-like shadow. That is called signet ring bronchus. That is a CT shows the signet ring bronchus. Then associated with the clinical symptom, increased dyspnea, increased cough, fever, increased wheezing, reduce the pulmonary function. The pulmonary function, the FVC value is markedly reduced. Then dilatation of the bronchi, that is beaded appearance. The dilatation of bronchi shows beaded appearance. Then for that, then suspected case of bronchitis, you must advise the CT. The CT report shows the first one is the signet ring bronchus, and second one is the beaded bronchus, and third one is in cystic. It will show the string or cluster of cysts. These are the classical presentation we have seen in bronchitis. Then another condition under COPD is a chronic bronchitis, then under obstructive lung disease. Then cough, then sputum production very clear, white, yellow, associated with the hemoptysis, dyspnea, wheezing, then fever with the chill. Then X-ray shows the bronchial wall thickening, increase in lung markings. That is an arrow, red arrow shows that. Then my request that chronic bronchitis, then not only we are dependent the investigation, simultaneously we are thinking about the definition of the chronic bronchitis. The definition of chronic bronchitis, the three things: the consecutive 3 months, the continuous cough and sputum in a consecutive 3 years. This presentation is there. X-ray shows the bronchial wall thickening, that is the bronchovascular markings are prominent. That is an arrow shows the bronchovascular markings are prominent. That definitely we are able to diagnose is the case of chronic bronchitis. Then high resolution CT is a confirmation of chronic bronchitis. That is CT shows the thickening of medium-sized airway. Then pulmonary function test. The pulmonary function test, mainly they are used for then determine FVC value and FE1 value. Then mainly we are focusing the spirometrical values is related to volume and capacity. The different volume and different capacities. The different volume and capacities. Then here the two values are very important. One is the FE1 value and FEC value. Here the forced expiratory capacity in pulmonary function test in chronic bronchitis? The forced expiratory capacity. After a normal expiration, again a forced expiratory effort. That is an almost around 2000 and something. That is forced expiratory, that capacity is markedly decreased. Then again, the residual capacity is increased. The residual capacity is an increase. That means after the forced expiration, remaining air inside the lung, that is called is a residual capacity. That is, it will increase, but at the same time, the forced expiratory capacity is drastically decrease. Then blood routine, the hematocrit values are increased. The partial oxygen value also decrease. These are the associated feature in along with for our chronic bronchitis. The next, emphysema. Emphysema is a common issue in our day-to-day practice under COPD. Under COPD, if COPDs are under, then majority of the COPDs are under obstructive lung disease. Then emphysema, the productive cough, very clear to white sputum, dyspnea, minimal exertion, pink puff or squeeze. Then X-ray shows, then normally our X-ray shows the bronchovascular markings are present. But what happened in emphysema? Emphysema means the dilatation and deterioration of, just you are assume our bronchial tree, like just you bring a plant, then just you are clear the roots, then plant root, the two types of roots are there. One is the tap root and then again the fibrous root. Then tap root and fibrous root like structures we are seen in our X-ray, we are called it as bronchovascular markings. Then divisions of the bronchi is like this. Our principal bronchi divided into primary bronchioles, then secondary bronchioles, then again further division tertiary bronchioles, then terminal bronchioles. That area is very important. The terminal bronchioles, and this the diameter always in between 3 to 5 millimeter. The inside diameter always. The tertiary bronchi, the diameter, then 3 millimeter, 3 to 5 millimeter. Then terminal bronchial division again divided into two, proximal and distal. The distal always below 3 millimeter diameter. Then again, the terminal bronchioles, the distal of the terminal bronchioles, the next division of the terminal bronchiole is the respiratory bronchioles. That means including distal part of the terminal bronchioles, respiratory bronchioles, then last alveoli. These three INDs, the three anatomically three structures, and this dilatation and deterioration is called emphysema. Then suppose then our alveoli isn't dilated, what happened? Then more air inside the lungs, more air inside the alveoli. Therefore, the normal air presence in our X-ray, the term here used translucency. That time more air is inside the alveoli, the term here used hypertranslucency. The more air inside our alveoli, what happened? The adjacent, the bronchovascular markings we are not able to see. Therefore, absence of bronchovascular markings. That is called AD pattern. AD pattern, arterial deficiency. The arterial deficiency, hypertranslucency. These are the classical evidence of emphysema. Suppose alveoli is dilated, that time the total lung parenchyma is dilated. The total lung parenchyma is dilated, what happened? More pressure exerted over our diaphragm. This is our diaphragm. The diaphragm is flattened. The diaphragm is flattened. Then again, absence of bronchovascular markings. Therefore, our AP diameter, anteroposterior diameter is varying. Due to the AP variation, anteroposterior diameter variation, what happened to our ribs? the ribs are widening and straightening. These are another the classical X-ray evidence of emphysema. Then HRCT shows the high resolution. The computed tomography shows the enlargement of alveoli and destruction of alveolar wall and increased alveolar wall thickness. Then, like our pulmonary function test, it shows increase in total lung capacity. The total lung capacity is increased, decrease in vital capacity, especially when vital capacity forced expiratory volume. After normal expiration, then forcefully you are expired. That volume is the decrease, markedly decrease. The decrease in vital capacity and as well as the forced FEV volume is decrease. Then blood test normally, then increase in level of hemoglobin. Why the increase in hemoglobin level? Then the reason is a compensatory mechanism. The compensatory mechanism for the more the oxygen is maintained in the tissues, the suppose the due to the overinflation, the normal internal respiration is not happen there. Internal respiration means then oxygen from alveoli to blood vessels in blood stream. Then suppose from the alveoli is then the alveoli is dilated, that due to the lack of the oxygen, what happened? Then oxygen inside the blood also decrease. Then suppose then a feedback mechanism is controlled by our brain. Then your information is given for the maintenance of the oxygen saturation is an increase the production of the RBC. Therefore, our hematocrit value, especially the hemoglobin level, is increased. The same mechanism happen in valvular heart diseases. Valvular heart diseases. Therefore, the markedly then hemoglobin is increased. Then packed cell volume also increase. Then in blood, then alpha-1 antitrypsin deficiency, then increase, then partial CO2 level is increased. These are the classical investigatory findings in emphysema. Then next, I would like to highlight the occupational lung diseases. Occupational lung diseases. The first we are discussing asbestosis. Asbestosis, you know, is a shortness of breath, coughing, then tightness of the chest and chest pain and clubbed fingers. Then another very important one is if we are collecting the right history of the presenting complaints. In case of occupational lung diseases, we should they are trace out the occupation. That means the histories are very important. In addition to the histories, then above mentioned, then symptoms are there. Here indication of asbestosis. Then because shortness of breath, the tightness of chest pain, clubbed fingers. That's very all to the occupational lung disease. One of the classical finding is the clubbing. Clubbing, everybody knows. There are two pathogenesis is there. The mechanism is there. One is the dilated blood vessels, then arteriovenous shunt. Then second one is pulmonary osteoarthropathy. Then suppose the clubbed fingers in asbestosis, it will producing the pulmonary osteoarthropathy is a common. Then X-ray, that normal X-ray, it shows bilateral nodules are seen in the lower lobe. They look like the patchy opacity. That means that traditional X-rays never helpful to work out the nodules, but the finding is the patchy opacity. So many other lung conditions, respiratory diseases, the chest X-ray shows the patchy opacity. For the confirmation, just you are advised computed tomography, that is CT scan. The CT will shows ground glass opacity, ground glass appearance, that is indicating, that is peripherally indicating that ground glass appearance indicate the pulmonary fibrosis. then subpleural curvilinear opacity. These are the two features here seen in CT. Then pulmonary function test shows, then because it will producing, in addition is not than the obstructive lung disease, it will producing restrictive pattern. Restrictive pattern means that is then forced, then FE1, forced expiratory volume at 1 second is the normal. Then because already due to the restriction, then a limited amount of air inside the alveoli. But that air is expelled within 1 second. Therefore, at 1 second, then for expulsion, the enough air is there. Therefore, FE1 value is the normal. But FEC value is markedly decreased. There is a classical finding of restrictive lung disease is just opposite to our obstructive lung disease. I repeat, then obstructive lung disease, then spirometrical value, then FE1 value is decreased because due to inside the bronchus obstruction is there. Therefore, in first second, the normal expected air is not expelled out. That due to obstruction. Therefore, FE1 value is decreased, but gradually then entire air from the alveoli is expelled out. Therefore, SPC FEV value is normal. But restriction just opposite. The FE1 value is normal, but total volume is decreased. Then next, cold workers and pneumoconiasis. The cough, the like our presentation almost the same. Shortness of breath, chest tightness, cough, bring black mucus, then etc. But X-ray shows the nodules and there is an the corballine, it tends to have less well-defined margin and a more granular appearance on the upper lobe. There is a nodule like the pattern we have seen in our upper lobe. Then another occupational lung disease condition is silicosis. There is cough, sputum, and progressive shortness of breath. There is the classical finding is eggshell calcification. Calcification we are identified. Then there are two colors there in X-ray. There are two colors, the black and white color. The shades of the different shades of black and white we are considered. Then suppose we are visit a textiles, we are just to work out the different shades of white. All are white, but the different shades are there. Shades are then we are concentrating each and every white is difference is there. Likewise in our X-ray, the bone density is white in color. The calcification also again white in color. Bronchovascular markings are again white in color. Then in pathology, and suppose the fluid is collected white in color, then inflammatory X-ray white in color, all are white in color. But we are concentrating our X-rays. We are seeing the different shades of white we are present there. Their change of white, the change of colors. Then here, then calcification means the glazy, the most glazy white is a classical presentation of calcification. For the confirmation, again, you should advise the CT scan. It shows well-defined nodule, again 2.5 millimeter. Then here you remember, in all the occupational lung disease is the presence of the nodule, the cyst and cystic nodule. Then 2 to 5 millimeter, predominantly in centrilobular and suboral region. Then bronchial mucosa biopsy shows the presence of the silica particles also seen. Then is that biopsy is very useful for the diagnosis of the silicosis. Then for that, then sample collected through the bronchoscopy. The bronchoscopy reveals the collection of the material. This is a blackish pigmentation of the mucosa. Then through the bronchoscopy, we are able to work out that is the lining membrane is in shades like then blackish pigment is another indication of silicosis. Then berylliosis is the same. The CT small nodule is not a well-defined unit, very small nodule with the perilymphatic distribution of ground glass appearance. In very later stage only, that is, this CT finding is there in berylliosis. That is another condition in occupational lung disease is siderosis. In siderosis, then features like breathlessness, coughing, decrease the lung function. Then hypersensitive pneumonitis. Then in siderosis, and also it will shows bilateral nodule. Earlier I say in all type of our occupational lung disease is an X-ray shows the nodular opacities in all zone. Then here in siderosis, in all the zones we are seeing bilateral nodular pattern, nodular opacity. Then in hypersensitive pneumonitis, then X-ray shows airspace shadowing. Then CT shows again bilateral ground glass opacity. The pulmonary function test, then here it shows restrictive function, restrictive lung sign. Then therefore my request, then obstructive lung disease we are differentiating from occupational lung disease. Occupational lung disease, the spirometrical value shows the sign of restriction. The sign of restriction means FE1 value is normal, the FVC value is drastically decreased. Then next we are discussing interstitial lung diseases. In interstitial, another group of disease, interstitial lung diseases, sarcoidosis is a condition. In sarcoidosis, the persistent dry cough and shortness of breath, pain and swelling in joints, weight loss. Then X-ray shows the bilateral hilar lymphadenopathy. The bilateral hilar lymphadenopathy. In X-rays, we are look over the fourth intercostal space. The fourth intercostal space. This an arrow shows the fourth intercostal space. Here, patchy opacity is this area of hilar lymph node is the fourth intercostal space. Very easy to work out the fourth intercostal space. The fourth intercostal space and anterior part of the posterior ribs, the fourth intercostal space. Then hilar lymphadenopathy, we are also seen in the pulmonary tuberculosis in primary complex. In primary complex, then associated with Gone-Focke and the third classical feature of the primary complex is it will producing caseous necrosis. Hilar lymphadenopathy, it will have caseous necrosis and Gone-Focke. These are the classical features of primary complex. But here in our sarcoidosis, only this hilar lymphadenopathy. Here, not unilateral, bilateral hilar lymph node enlargement. Then CT shows, then ground glass opacity is a subpleural nodule. Then thickening of the interlobular septa. Is a ground glass opacity is an indication of the so many conditions, the ground glass opacity. Then associated with the irregular thickening of vascular marking. Then again, here consider the history of the patient. Then normal blood routine test shows the elevated angiotensin converting enzyme AEC, that is angiotensin converting enzyme is greater than 40 nanomole per milliliter per minute. That is a classical evidence of. Then supposed to be than any other investigation. This blood routine plus blood investigation shows there is an angiotensin converting enzyme ACE. It will shows that greater than 40 nanomole. Then the blood routine, another finding, it will shows low white blood cell count. The WBC count is decreased. Then associated with the sarcoidosis, workout liver biopsy, the presence of epithelioid granuloma. Epithelioid granuloma. The next condition is idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is shortness of breath, tiredness, loss of appetite. Then all the occupational lung diseases, we are already discussed with you the presence of clubbed fingers. In interstitial lung disease is an pulmonary fibrosis, also clubbed fingers. Is an X-ray shows is a net-like linear, the curvilinear densities. That is a peripheral reticular opacities we are seen in our traditional X-ray, like this. Then for the confirmation, then traditional X-ray is never helpful for the final confirmation. Therefore, we are dependent, we are advised, or dependent, or otherwise we are advised other investigations. Mainly, our investigation include our high resolution as an HFCT. It's a patchy peripheral, subpleural, and bibasilar reticular opacities. Then subpleural, then another a classical feature, honeycomb appearance, is means the less than 5 millimeter round translucency we are seen in our CT. Then associated with the thickened interlobular septa. Then we are doctors, we are medical practitioners. Therefore, we are aware about what is the reason that formation, that is the pathogenesis and relationship with our radiological evidence. That is a honeycomb appearance. The blood routine is shows the specifically anti-nuclear antibodies are positive. The ANA profile is a positive. Therefore, in ANA, everybody know the autoimmune disease. Then autoimmune disease, then one of the major respiratory presentation is a pulmonary fibrosis. Therefore, always then ANA, then anti-nuclear antibody is positive. Then C-reactive protein markedly increase. Then normal blood routine shows ESR level is increased. Then other tests include our pulmonary function test or spirometrical test shows then progressive decline of the forced, that is the total capacities decrease. There is a restrictive ventilatory defect. Another condition is in respiratory bronchiolitis associated with interstitial lung disease. Is in classical presentations are cough, breathlessness, then crackles on examination. Crackles, one of the adventitious sound. We are expected while during the auscultation, crackling means the light. Our dry hair, we are in between the two fingers, we are crushing, we are heard a sound. That is a crackle sound. One more definition is there. Then suppose we are fine powder of our salt powder. Just we are poured over the fire. That time we are heard a sound. That is a crackling sound. It is associated with X-ray shows. It's a bronchial wall thickening. the diffuse fine reticular nodular opacity. Then CT only help for the final diagnosis. It will show centrilobular nodules and patchy area of hazy ground glass opacities. Then other investigation include the CRP level C reactive protein is increased. Then here our white blood corpuscles WBC count is markedly increased. Then other test is a pulmonary function test. Increase the residual volume. Is an shows the mixed pattern of obstructive and restrictive lung pattern. The both are we are seen in bronchiolitis, respiratory bronchiolitis. Next condition is a cryptogenic organizing pneumonia. Is a flu-like illness is an associated with the then in flus the common symptoms are there malaise, fatigue, weight loss. Then another in crypto-organizing pneumonia is a progressive cough and exertional dyspnea. X-ray shows bilateral diffuse peripherally distributed alveolar opacity. Then our CT scan shows the patchy airspace consolidation. Then blood routine in your look over leukocytosis. The leukocytosis means the high level of neutrophil count is increased. The total WBC, the increase means in WBC, the predominant cell is the neutrophil. Therefore, neutrophilia. Or another name, agranulocytopenia. Agranulocytopenia. Then blood routine test, the agranulocytopenia or leukocytosis. The other tests include pulmonary function test shows the restrictive defects. Then lung biopsy also depend for the cryptogenic pneumonia. Lung biopsy is a proliferation of granulation tissue within small airway and alveolar ducts. Is an in cryptogenic organizing pneumonia. Next condition. Next condition is a lymphocytic interstitial pneumonia. It's a very rare condition. Then X-ray is never helpful for you. That is alveolar opacity. In addition to this, blood routine shows serum protein level and immunoglobulin levels are increased. There is very two important finding in interstitial pneumonia. The serum protein level and immunoglobulin level is increased. Then CT shows the thickened brongovascular bundles. Then another condition in non-specific interstitial pneumonia. Then next we are discussing respiratory failure. Respiratory failure. The classical features are dyspnea.
How much time you needed?
Sir, within 5 minutes I will wind up, sir. 5 minutes.
Okay.
Then second part we are include the remaining part, especially our therapeutic part.
Yes.
Then now that these are the general investigation we are completed within 5 minutes, sir. Okay. Respiratory failure, common symptom, dyspnea, hypoxia, and hypercapnia. Then here in diagnostic part, the more useful tests are blood gas analysis, arterial blood analysis. Then non-invasive, the pulse oximetry and chest X-ray shows underlying the pathology. Then partial oxygen falls below 60 mmHg in respiratory failure. Then suppose in clinical side, the partial oxygen level is a decrease below less than, falls below 60 mmHg. We are one of the diagnostic criteria for respiratory failure. But the same hypercapnia is the partial ions rise more than 49 mmHg. These two finding oxygen level is partial oxygen level is decreased and CO2 level is increase. Associated with the hypoxia and dyspnea is there. we are able to diagnose is a respiratory failure. Then type 1 hypoxemia in respiratory failure, it will show pulmonary sign of pulmonary edema. Then the sign of the fluid built upon lack of surfactants causes poor oxygen perfusion. Then it will also show the sign of pulmonary fibrosis. Then the type 2 hypercapnia and type 3. Then type 2 hypercapnia, then greater than 50. The partial carbon dioxide level is greater than 50. But at the same time, our forced respiratory volume less than 1.2 liter. Then the type 3, the peri-operative respiratory failure, that is common in post-anesthetic atelectasis. Atelectasis means the lungs become strangled. The classically, our functional residual capacity, FRC value is drastically decreased. That is, these are the different pattern we are seen in the respiratory failure. Then one more in respiratory failure, the last type is type 4, that is a hypoperfusion of respiratory muscles in shock. The sign of then X-ray shows pulmonary edema. Then another the classical evidence of hypoperfusion of respiratory muscle in shock is associated with the lactic acidosis. Then as in shock patient, the commonly associated with the anemia. Then another condition is the inflammation of the pleura. The CT shows thickened pleural wall thickening. Then intercostal tenderness on palpation. Then here in pleuritis, the dry and wet pleurisy. In dry pleurisy, only the patient in clinical side presenting the pain. The intercostal tenderness, while touching the patient feels the pain. But the wet pleurisy, what happened? The visceral and parietal pleura is separated. Due to the separation, what happened? That during the inspiratory or expiratory time, these two layers are not reaching the rubbing, rubbing. Therefore, there is no pain because in between these visceral and parietal pleura, the fluid is accumulated. Therefore, both are separated. Therefore, in this manner, clinically, we are separating the pleurisy and dry pleurisy and wet pleurisy. And next class, we are start with the respiratory system, the therapeutics. Then today, we are then common condition, we are leave it. And what are the uncommon respiratory diseases? Then all the respiratory diseases are commonly differentiated, mainly differentiated obstructive and restrictive. In addition to this, we are discussing the interstitial lung disease, respiratory failure, then certain other conditions like idiopathic pulmonary fibrosis, then sarcoidosis included under interstitial lung diseases. Then broad division, the restrictive lung disease and obstructive lung diseases. Suppose the next class, we are included the investigation related, then associated with, here related with our therapeutic path. Once again, I convey my thanks to our organizers that give me opportunity to present a topic related to our respiratory diseases, respiratory investigation. Thank you, sir.
Okay, nice presentation. And this indicates or shows that we need more specialists. Otherwise, we can't remember all these things. But in a graduation level, it is not at all possible for a student to study all these things along with the homeopathy subjects. Very extensive topic. So that's the most important thing. I think we don't have such courses in homeopathy, the fellowship courses. And so the super specialty level courses are not in there. But in fact, we can have successfully such courses because our therapeutics is that much rich. Time for discussion. Those who would like to participate, please raise your hand. Dr. Ajayan extensively discussed all these things. The common thing and uncommon thing. If you diagnose a rare disease, then you are rarely correct. Is often said in our medical textbooks. And what is often vexing is the uncommon presentation of a common disease. That's also an important thing. So to become a clinician, we must have a thorough knowledge in all these things. If anybody would like to ask some questions or make some additions, please raise your hand. Especially these topics are very relevant in this post-COVID situation. A lot of patients are suffering with this COVID condition and are present with whether it is vaccine originated or the actual diseases. Otherwise, the artificial disease or a natural disease. Dr. Dhanesh is there. Dr. Dhanesh, you can unmute now.
Yes, good evening, Ajay sir. It's really a very
Good evening, sir.
once again, it shows the beauty of investigations and why homeopathic doctors should do all these kind of investigations. This is a deep subject. You have shown how beautifully it can be studied and it can be utilized for our professional use. And I still remember a case when we have a patient in front of us and the patient is not revealing everything. We just I just examined the chest of the patient and I found that her heart is on the right side. So when I told about the same, the patient was hiding. They know that actually it is there, but they were testing the homeopathy in me. But I just answered that it is a normal problem as far as the heart is on the right. Even though it is in the right side, it doesn't make any much problem in the future. Then only they told me that these kind of things are there, and they really appreciated our effort. They never thought that a homeopathic doctor knows all those things. This is a pathetic situation as far as the public is concerned. So all those tests you narrated here are really very, very important tests, and everyone should study those things.
Another, sir, excuse me, another information for why this type of the investigations are essential. Then, for example, just we are presenting in front of in a scientific world, just you are presenting a case through an article. Suppose to be an article. Then we are say in our knowledge basis, we are say a disease is a COPD. Actually, just after the writing the article, even the first time, even the good editors are there, reviewers are there. Then very first reviewing that just your objection is there. Then because the reason is then homeopaths are not able to the right way, we are not able to diagnose the cases. That because the enough investigation is not there. We are just a few investigation ways we are diagnosing the case of COPD. But the scientific world is not accepted. Therefore, the detailed investigation very essential for the publishing a paper.
Yes.
Therefore,
okay. Okay. Now, Dr. RESPIRATORY is there. Dr. RESPIRATORY, can I please unmute? Only 3 or 4 minutes remaining. Yes, please.
Hello, Ajay. Since a long
Yes,
time
ma'am.
you are seeing in this platform.
Okay,
It's
sir.
very nice presentation, even though it is too difficult for me to remember all these things, to understand all these things in this age of 76. It was very nice. At least for youngsters, it is so useful. Thank you, Ajay. Why you are not coming frequently? You should come and have these presentations frequently, okay?
He is very
Okay,
busy.
okay,
At this
okay.
time also, a lot of patients may be waiting outside. After 9
Yeah,
o'clock, attend them. Okay, now Dr. Hariran sir, yes, please. Hariran sir, you can unmute now. Hariran sir, you can unmute now. Yes,
Okay.
please.
Hello, Dr. Ajayan. Your
Okay,
class really highly commendable. Very, very good class and very informative. But see, nowadays, after COVID, a lot of patients are coming with respiratory complaints. I inquired my colleague, one doctor, one PG doctor, he's a pulmonologist. I inquired him why it is so. A lot of cases are coming. A lot of cases are coming due to respiratory complaint. He told me that after COVID, lungs became, fibrosis happens in the legs. Fibrosis. It is a condition now. We are facing. Homeopaths and allopaths are facing such a condition, and the coughs do not subside even after giving medicine 1 or 2 weeks. It will not cured. So even they are also in confusion which medicine they must give.
Yes.
They are also in confusion that now they are using that cortisone. But continuous cortisone, they are fearing to give continuous cortisone. So depends. Patients are depending to a homeopath, and we can give the medicine, and we must give the medicine not 1 or 2, 3 or 3 days, but for 1 or 2 weeks, we can cure that case. So
Yes, sir.
it is my experience.
Yes, yes. Okay.
Okay, thank you, sir.
Yes,
Okay, thanks.
time to wind up the session. May I invite Dr. Ram Purvai to express sort of thanks. A very senior physician. Sir, please unmute. Yes, sir.
Thank you, everyone. Thank you, Manojji. Very, very thanks, Dr. Ajayan sir. Very nice presentation. Excellent session. Therapeutic of respiratory tract diseases. Differential diagnosis. Very difficult diseases after post-COVID. So very, very thanks.
Okay.
Behind of IFPH, very, very thanks, sir.
Thank you, sir. Thank you, sir.
Again, presentation and IFPH. Thank you.
Thank you, sir.
Well,
Thank
these
you.
videos are regularly uploading in the YouTube. So please all kindly watch the videos and make your comments on that. So with that comment, let me conclude today's English edition. Hope you that we will meet again tomorrow. Till then, goodbye. And over Dr. Shaila for the continuation program in Malayalam.